Afternoon, everybody. I'm again here with this presentation. You could literally call it marketing SICS. I'm Ranjit DHALIWAL from Nabha. It's got a very small population, 95,000, surrounded by a vast rural hinterland, connected to Delhi by just 2 trains. Saving Grace is an international airport within 90 kilometers of Nabha, which I think would be better than the circumstances in Delhi. This presentation, as all my presentations are dedicated to Vikram, this too is dedicated to him. The title of this presentation is Manual SICS, a surgery for all seasons, a surgery for all reasons, but I have added this why before it. Ophthalmology today, as it was 35 years back when I first made this presentation, is still on its cutting edge. Better, not necessarily the finest equipment in association with absolute dedication to ophthalmology to provide personalized care to even such patients is the necessity. The aim is to provide dedicated and professional care. Improvisation and indigenization brings the latest technology to the multitudes of masses of our country at a reasonable cost. A modern setup at the primary level can boast of quality services and does not cost a fortune, I would say, in the present day circumstances. Now, why manual SICS? India, a land of vast disparities, still presents at any given time a linear panorama from ancient couching to modern phaco and femto. Manual SICS fits in at all levels, a surgery from primary to the most advanced level of patient care. Cataract surgery is no longer a simple rehabilitative procedure, it's an extremely precise refractive surgery, goal being emmetropia, though not exactly these days. Manual SICS is easy, I would say, provides all the advantages of a small incision with few complications. I call it a hazard-free, but people tell me it's more difficult to master than phaco. It has a smoother and easier learning curve, rather no learning curve for one already into ECCE and implant surgery. It is in fact a revolutionary technique, ideal for teaching institutes, government tertiary centers, and or wherever finance is a constraint. It has arguably the same objective and results as phacoemulsification, presumably not a single absolute contraindication. Charm of SICS is its simplicity. It's a no additional cost option and little extra investment is required. A hard black cataract, any surgeon's nightmare, is just a single step procedure removing such a nucleus in SICS. Nucleus can be delivered with a fish hook made of 26 gauge needle and irrigating vectis alone by the sandwich technique or by the hydro or visco expression technique. Cases of cataract coexisting with most of these comorbidities have all been taken up for manual SICS at our center at one time or the other. It is a must for phaco surgeons for times when they have to convert due to phaco machine failure, posterior capsular rupture, zonular dialysis, hard black or brown cataract, or having used too much phaco energy. The phaco machine and the paraphernalia that goes with its instrumentation, sterilization, repair and replacement are a costly luxury for entry-level small clinics. Though we were able to buy this particular machine later on, but still our phaco rate was only 5%. Rest was all SICS. And my most controversial slide, phaco machine out of order. The ordeal begins. Sales and marketing team, efficient, slick and polished. After sales service department, I would call even in the biggest hall, callous, indifferent and unreasonable. The less said, the better. Phaco surgery has a hazardous and steep learning curve and arguably is a time-consuming procedure for people other than the masters. This word arguably was put here in this slide because of my friend Dinesh Verma. He said many people would think otherwise. Common problems faced with in cataract surgery can all be tackled with manual SICS. A superiorly placed trabeculectomy bleb, a large hair knot on the head as supported by the holy men in India. Traumatic cataract and pre-existing PC defects are no contraindications. This was a difficult case, deep set eye with a narrow palpebral fissure. We performed canthotomy and went ahead with manual SICS. And I started doing temporal very early. Advantages being the external scratch incision may be placed right on the limbus instead of going through the sclera. By opting for the temporal approach, we are able to bypass the eyebrow in a deep set eye, and the bridal rectus suture is not necessary. Irrigating fluid flows down through the lateral canthus, so no chances of backflow of the fluids. In oblique astigmatism, I would just move the tunnel superiorly or inferiorly, placing it tangential to the steep meridian. As I used to move inferiorly, Vikram started went over to the superionasal side also. Superiotemporal approach is also used in cases having no astigmatism. This is a case of one of our cases of temporal SICS the day after. In manual SICS, I would say the final results are arguably again extremely good in the learning period, but fascinating once the technique is mastered. Thank you for your patience.
Thank you, sir. Thank you, Dr. Ranjit.